Welcome to tonight's webinar, Asthma and Pleural Infection, Essential Updates for GPs. We are joined tonight by speakers Dr. Matthew Ng and Dr. Lewis Holmes. Our GP facilitator is Professor Charlotte Hesby. My name is Jasmine and I'm your RACGP representative for this evening. Before we get started, I would like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past, present, and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. I would like to introduce you to our presenters for this evening. Dr. Matthew Ng is a visiting medical officer at Macquarie University Hospital and a staff specialist in respiratory and sleep medicine at Liverpool Hospital. He has a focused clinical and research interest in interventional bronchoscopy and pleural disease. Dr. Lewis Holmes is a respiratory and sleep physician specializing in the management of airways disease such as asthma, interstitial lung disease, and the rapid investigation and management of pulmonary nodules and lung cancer. Our GP facilitator is Professor Charlotte Hesby. Charlotte is the Head of General Practice and Primary Care Research for University of Notre Dame School of Medicine, Sydney, and works part-time in clinical general practice in inner city Glebe as a principal of 16 doctor group practice. Welcome to all of our speakers, and I will now hand over to Charlotte, who will go through the learning objectives.
Thank you so much, Jasmine. Really excited to be the facilitator for tonight. So we're going to go through say two speakers. So we have Lewis and Matthew, who are going to be presenting that for us. The first will be on pleural infection, explaining the burden, discussing the management of pleural infection, and then we're going to move into asthma, where we're going to summarise the recent updates in asthma guidelines, explaining the importance of inhaled corticosteroids in current management, describing airway endotypes in asthma management, and how to identify asthma patients who are high risk of exacerbations, morbidity, and mortality. So, with no more wasted time, let's move straight into our first presentation, where I will invite Matthew to be able to take us through the whole issue of pleural infection. So thank you so much, Matthew. Over to you.
Thank you. Thank you for the invitation to talk tonight. I just wanted to outline just briefly the points of my talk. So we can go to the next slide. I guess one of the most important points is why does it matter, and why does it matter to primary care practice? And I hope to kind of elucidate some of those points for you. Increasing the burden of pleural infection, how it basically reflects the patient population, which is aging with multi-comorbidities. So analysing the increasing burden of the disease, and then highlighting most of the important points through a case study, trying to help identify those who are at risk of developing pleural infection, particularly if it's related to pneumonia, treatment of pleural infections, and also preventing long-term complications of pleural infections. So why does it matter, and why should it matter to you in primary practice? Well, we know that pneumonia is very, very common. Up to 2.5 million patients per year die from pneumonia, so it poses quite significant mortality alone. 50% of patients with pneumonia will develop a pleural effusion, and that's associated in itself with a 3 to 6 time increase in the mortality. Pleural infection represents significant health cost utilization, and average length of stay with a patient with a pleural infection is between 14 and 19 days. So it has significant morbidity, mortality, and also health cost care expenditure. So it's an important problem we need to address. The burden of pleural infection, like a lot of the diseases we're seeing, it is rising incidence worldwide. The graph there just shows hospitalization rates per 100,000 adults population over the y-axis, and the time frame is between 1987 to 2017. And in the Western world, the general trend is an uprise or uptick in hospitalization rates. And you can see the blue dots and the graph and the green dots there, the USA. Europe countries are basically represented by the orange dot in the UK, Denmark in the grey, and Taiwan, Southeast Asia in the brown. And in general, the trend is a slow uptick, and that probably represents the aging population, multiple comorbidities, greater use of immunosuppressive drugs, and probably the evolution of bacterial infections and their evolution against antibiotic resistance. We know that the burden is high because patient outcomes really have not significantly improved over the last 20 to 30 years. We know that mortality rate, 30-day and 3-month mortality rates are approximately 10% in patients with pleural infections. And their 1-year mortality rate is approximately 20. And this rises in patients who are elderly or immunocompromised, and that can rise up to 35%. So I thought I'd try and highlight some of the important points for a case study. This is a patient that presented to our other hospital, Liverpool Hospital, within the last month with a pleural infection. He was Mr. AA. He's a 50-year-old gentleman who was an Iraqi refugee. He came to Australia in 2003. He's married. He had a child. He was initially a carpenter in Iraq, but in Australia, he's a long-time carer, a full-time carer for his disabled son. Interestingly, in June 2025, he presented to his GP with some dental pain. He was investigated with an OPG and is referred on to a dentist for further investigations and testing and treatment. That's an important point, and I'll kind of touch back on that in a second. Now, subsequent to this presentation in June, he came back to the GP in September 2025, and he presented with a 1 or 2 week history of right upper quadrant, kind of vague right to the chest pain and associated high-grade temperatures of 39 degrees. The GP, rightly so, organised some outpatient pathology and imaging. A bit more background, Mr. A had some past medical history, some cardiovascular risks, hypertension, diabetes, hyperlipidemia, some depression, reflux, and he was an ex-smoker of 35-pack-year history without kind of diagnosed airways disease. There was no illicit substance use in the past. Medications weren't too impressive, some antihypertensives, antidepressants, and obviously medications to control his diabetes. These are some outpatient bloods, and obviously, thank you. These are outpatient bloods, and I think just to draw your attention to the white cell count, he had a significant neutrophilia. White cell count total was 20.1. He probably had a reactive thrombocytosis with a platelet count of 556, and what seemed to be an acute kidney injury with creatinine 185. He didn't have evidence of diabetic nephropathy. So, for all purposes, this guy had some sort of inflammation or infection, with the money probably being on a lower respiratory tract infection with normal liver function tests. So the initial management plan from his local practitioner was he was commenced on an oral course of amoxicillin and doxycycline, which would be standard practice, and I would agree with treatment for mild community-acquired pneumonia. The follow-up plan was 1 week post-initiation of these antibiotics, and some investigations were obviously organised in the meantime. From what I believe, a chest X-ray form was sent or given to the patient, but he didn't unfortunately do the chest X-ray. To investigate the acute kidney injury, renal ultrasound was performed, and it showed no evidence of obstructive uropathy. Just harping back to the point of his previous presentation in June, an OPG was conducted and it demonstrated some peri-apical lucencies and a number of teeth, reflecting some sort of inflammatory pathology. And there was widening of these periodontal ligament spaces, raised suspicion of root fractures. And there was some suspicion that there were kind of chronic dental infections in this patient all the way back in June of this year. So the presentation, when I first met the patient, was in early October. He was reviewed again by his GP, and he was actually advised after a quick review to present to the emergency department. The major, his symptoms were progressive chest pain and high-grade temperatures in the 38 to 39 degrees. His vital signs on presentation to the emergency department was a normal saturation. Blood pressure was low, borderline low. Temperature was obviously high at 38.3 and a respiratory rate of 18. I've just taken a snapshot of the bloods that were taken at that time. Clearly had some electrolyte derangement with hyponatremia and some hyperkalemia. His LFTs had then gone off a little bit, more in a cholestatic picture, but with a normal bilirubin. The white cell count again was high, 18.2. Predominant neutrophilia up at 13.3, and then his CRP was very dramatic. It was very high at 331. So obviously this gentleman was would fulfill some of the criteria for sepsis, and he was started on antibiotics or intravenous antibiotics at the time. Obviously, with that picture, further imaging was conducted. And this is the initial imaging. So on the left-hand side of your screen, there's a chest X-ray. And just to briefly go through it, obviously there's a pacification on the right hemithorax. You can see very significant blunting of the costophrenic angle on the right, and probably fluid within the horizontal fissure. The interesting thing is already you can tell that the fluid isn't particularly simple. There's probably what we call a D-shaped sign, which is the opacity, which is on that lateral chest wall, suggesting that this might be a complicated empyema or complicated pleural infection / effusion. In hospital, as we do more investigations and more in-depth tests with multimodality imaging. The CT scan, both in the middle and right of your screen, demonstrate dense fluid with some compressive atelectasis in the right lower zone with some fluid inside the horizontal fissure. Interestingly, there doesn't seem to be an underlying dense pneumonia that's on the CT scan. So this looks like a pure pleural infection. On the sagittal cuts that you see on the CT scan, the fluid is loculated. It's up against the chest wall and rising all the way up to the apices. And on ultrasound, which seems to be the most sensitive type of investigation for pleural infection, we can get a good feel of the fluid's complexity. This shows evidence of septation, shows evidence of fibrin strands, and it's very likely that once we try and drain this pleural effusion, it will not drain easily. So day one, you hit our hospital and emergency department in our ward. Treatment for pleural infection probably hasn't changed for a century. It's drain the fluid, drain the pus if you can. And a small bored chest drain was placed into the largest locule. You can see there's been some slight resolution of the pleural effusion. However, there's ongoing opacity on the chest X-ray. The patient was commenced on intravenous tazocin, and the pleural fluid analysis, we use Light's criteria as we have for many decades. It showed a very exudative effusion with a very, very high LDH count and protein. Unfortunately, pH and glucose weren't sent off, but this is very characteristic of a pleural empyema or complicated pleural infection. Microbiology was negative, and it has remained negative to date. This is very common. Only about 30 to 40% of cases will be culture positive, and you really base on empirical treatment of antibiotics. The cytology demonstrates significant polymorphonuclear cells, so 95%, which would be consistent with pleural infection. Day two, so the drain was initially placed, about 400 mils of purulent fluid was removed, and the drainage slowed down, and then not much drained after 24 hours. As you can see, the chest X-ray looks very similar between day one and day two, with the chest drain still in situ. There's ongoing radiological evidence of pleural fluid and high inflammatory markers on the blood test. And the decision to instill intrapleural alteplase and Dornase alpha, and 3 out of the potential 6 doses were delivered over the next few days. This is probably the biggest change in the last decade of how we treat pleural infection. We don't just drain and give antibiotics and then send to surgery if it doesn't work. This new medication is medication that we instill into the chest drain and into the pleural infection to help drain the fluid and gain source control. So this is close to discharge. He did quite well. He had a 7-day admission with a chest drain, long-term antibiotics, and a few doses of intrapleural enzymes instilled into his pleural space. You can see significant resolution of his pleural fluid on the chest X-ray, and on subsequent cuts of the CT scan, there's still residual fluid and thickening of the parietal and visceral pleura. However, a lot of that fluid has now resolved on the CT scan. So in total, 7 days of admission, and that's very different to the standard 14 to 19 days that's quoted in the literature. About 1850 mils were drained over the course of his admission, and a PICC line was inserted with 4 weeks of intravenous tazocin planned. In general, we don't have a great kind of medical evidence to suggest how long we should give intravenous antibiotics for. In general, we extrapolate a lot of data from lung abscesses, and we would at least give a patient 2 to 4 weeks of antibiotics, and that could be a concoction of intravenous and oral antibiotics. So in terms of discharge, you can see when he came into our emergency department on the 2nd of October, his COP was sky high in the 3 to 400s. By day 1, 2, when we instilled the intrapleural enzymes, drained the fluid, and given him antibiotics, there's a significant fall in his inflammatory markers. So we have a really good hospital in the home program that managed the PICC line and gave daily intravenous infuses. We got in contact with his GP, obviously gave him clinical updates and arranged some follow-up. I think the pivotal point is the general practitioner. They help assess treatment response, and I'll talk about that in a little bit, how they would do that. We also look for and monitor for antibiotic complications that can occur, particularly intravenous tazocin. There's a large salt load. There's a lot of impacts to the liver function and renal function with IV tazocin. I think importantly, long term, they help address the cardiovascular risk. We know that is associated, particularly with the pneumonia, and as we're starting to learn pleural infection. And they follow up on these dental issues. I can't speak highly enough about how important controlling dental infection is with these type of pleural infections. So are we able to identify risk? Are we able to identify patients who may go on to develop pleural infection, particularly if you're treating for or suspect an underlying lower respiratory tract infection or pneumonia? A lot of the evidence will point to diabetes as being one of the most biggest risk factors or independent risk factors for pleural infection. They're twice as likely to develop a pleural infection, even within pleural infection cohorts. Malnutrition and alcohol abuse are important risk factors. Mental health issues such as schizophrenia are thought to be independent risk factors. And sometimes as doctors, we anchor our diagnosis. Sometimes we see pleural infection and think, okay, we've treated that and we can leave it alone. We need long-term follow-up, and that's where general practitioners really come into play. Pleural infection can concurrently occur with malignancy, and up to 30% can be underlying malignancy. So it's really important to follow these patients up 12 to 18 months post-infection. These are just a few tables of common things that patients with pleural infections have. I've already addressed a few of them. I think other big independent risk factors would be gastroesophageal reflux disease and respiratory diseases. In data from over 200,000 patients, they found there was many patients with comorbidities. The most common comorbidities were probably the top 4: hypertension, diabetes, stroke, and ischemic heart disease. So were we able to identify those risks in this patient? Mr. AA was 50. He's not particularly old. He's middle age. Did he have relevant comorbidities? Yes, he probably had, as a lot of them do, hypertension and also reflux disease. He had a degree of immunosuppression or diabetes, and he had chronic dental infection. So I guess initially, we could have probably predicted that this gentleman had a high chance of developing a pleural infection because of the risk factors. A lot of these are not modifiable, but some of them are. So how can that guide your treatment in primary care? How does pleural infection look like in the community, and what community-acquired organisms occur? So pleural infections show a very complex microbiome that differ quite significantly from pneumonia. A lot of the pleural infection is polymicrobial, so you're dealing with multiple organisms within the pleural space. You can see that these community-acquired pleural infections, majority of them are actually gram-positive aerobes, and the most common being commensal organisms, particularly that colonize the mouth. On the kind of bar graph, you can see strep viridans as being one of the most common community-acquired organisms. And that, as everyone knows, is within the mouth and within dentition. So poor dentition obviously is a risk factor for developing pleural infection. I think importantly, 17% of community-acquired pleural infection will also be anaerobes. And again, this plays into oral dentition and reflux disease. More and more now we're seeing increased rates of pneumococcal and Staph aureus as being part of community-acquired organisms in pleural infection. And therefore treatment in the primary care, if you commence antibiotics, should probably look at covering both gram-positive aerobes and anaerobes. And, in retrospect, it's always easy to look back, but whether or not we should have tried to cover for more anaerobic organisms, something like augmented dual fort, which has good gram-positive and anaerobic cover would be maybe one of my choices, particularly to step somebody down to. So this is a very simplified way of treating pleural infections. I think everyone knows that antibiotics and pleural drainage are the two most important points of pleural infection. I think this is where probably hospital treatment comes into play, which would be installation of TPA and DNase. And those combined enzymes have basically taken a lot of work away from the surgeons. This is basically our number one thing we do with complex pleural empyema or complex pleural infections. We use these enzymes, and there have been landmark trials that I'll mention in a second that show how effective they are. And if anyone's ever interested in reading more about pleural infections, there's a great ERS statement on the management, and that was published in the ERJ just a few years ago. So I wanted to touch on this landmark paper. It was published in the New England Journal of Medicine, and it's called the MIS2 trial. It was trying to assess when patients have a pleural infection, pleural empyema, they get antibiotics and they get pleural drainage. Can we improve their outcomes? This was published in 2010. And you can see on the graph on the left that the primary outcome was the change in the size of baseline pleural shadowing. So did the pleural effusion go away on chest X-ray? You can see 4 groups that were studied: placebo, tissue plasminogen activator group, DNase activator group, and when they combined TPA DNase together. And when the combined group, and which justifies our use in the hospital, they showed a 60% reduction in the baseline pleural collection. They showed 77% fewer referrals for thoracic surgery. And they showed a 6.7-day reduction in hospital stay. Similar complication rates were seen in all groups. So this has become basically the new kid on the block in the last decade of treating pleural infection, particularly in the hospital setting. So I thought I'd try and summarize what I thought the follow-up role of a general practitioner and how you can help these patients with pleural infection. Obviously, you'll be basically the go-to point in primary care assessing treatment response. Based on evidence to date, the best thing to monitor treatment response is obviously clinical, how the patient is feeling, how they're returning to activities of daily living. But CRP appears to be the sufficient as the biochemical marker of treatment response, particularly due to its low cost and availability. So I use CRPs quite regularly, and I would want to see a downtrend, a sustained downtrend, particularly if the patient's off antibiotics. There'll always be a radiological lag. So I tend not to do repeat chest X-rays on the patient every time I see them. Sometimes it can be a 3 to 6 month delay, and always understand that there's malignancy is at play. So I tend to do at the 3 to 6 month mark, I tend to do a repeat CT scan, and then I follow these patients, and the GP can as well, and obviously see them at shorter time intervals, to make sure that there's no underlying malignancy that's clouding the pleural infection picture. I think one of the most important things that I learned through a lot of my training over in Perth was addressing long-term cardiovascular risk. So from the pneumonia kind of population, as you know, the risk of cardiovascular events was, highest during the first year after hospitalization and remained high among controls through 10 years in compared to patients who were not hospitalized for pneumonia. And we kind of extrapolate this to pleural infection, as we know sometimes they can go hand in hand. So kind of aggressively controlling cardiovascular risk factors is really important. Smoking cessation, if applicable, if your patient smokes, and addressing the simple cardiovascular risk factors that I don't have to tell you guys about. This patient had hypertension, diabetes, that could be addressed. I think lastly, the follow-up of dental issues. So clearly this gentleman had problems since June, and it's probably, although we didn't culture any organisms in this pleural fluid, it's most likely the source of his infection. So unless we address the underlying issues with his dentition, he likely is at greater risk of redeveloping a pleural infection or even pneumonia. So I just wanted to highlight 3 points that kind of watch this space. I know you all know about the association between hospitalization with pneumonia and subsequent risk of cardiovascular disease. If anyone ever really wants to read a good article in The Lancet published in 2013 to talk about kind of the mechanisms behind why somebody with pneumonia would get cardiovascular disease and increase the risk over a 10-year span, Lastly, there's an article just recently published this year that are looking at developing a scoring kind of profile. It's called the DASHI score. The DASHI score is trying to quantify the risk of a cardiovascular event in the first 30 days after a pneumonia. And then this work is going towards potentially an evidence base of putting patients with pneumonia or maybe pleural infection in the future on low-dose aspirin. I think it's a watch this space. It might be very relevant in the next kind of few years. So to summarize, I thought my talk today, I hope you've gotten that the burden of pleural infection is increasing worldwide, and it's probably because we're seeing older and older populations who are multi-morbid. If you have always have a low index of suspicion of pleural infection, particularly those who have risk factors and you think have a lower respiratory tract infection or pneumonia, consider early oral antibiotics that target both gram-positive aerobes and anaerobes. I like Augmentin and obviously atypical cover in the primary care setting. If evidence of a pleural infection, always kind of think about early referral, as we know that early drainage has better outcome. And then long-term controlling modifier risk factors is really important in the patient. Don't miss the chance to modify those risk factors because the rate of cardiovascular disease or an event in the next 12 months is really high. Lastly, don't miss malignancy that might be hiding under the pleural infection. Thank you.
Thank you so much, Matthew. Can I just reiterate the importance of understanding the increased risk of cardiovascular disease risk? Because I actually don't think everybody knows it. So it is this big thing about that patients at high risk of respiratory illness actually just, if you're looking at their death rates, they actually die more from their cardiovascular disease than they do from the respiratory illness. And it's because there is this very big sharing in comorbidity preventable risk factors. So that take-home message of this is a really wonderful red flag to say, go for gold in going for their risk factors. Because you're going to really save that death from the heart attack in the next couple of years as well. Thank you, Matthew. So now, Lewis, we can hand over to you, and we're going to be taken through all of the new stuff that we need to know about asthma. So thank you.
Yes, thank you, Charlotte. Thanks, Matt, for your presentation. I'll just get my slides going here. Okay, looks like it's working. All right, so I'm going to talk about asthma. Primarily, I want to discuss the recent guidelines released by the National Asthma Council in September. There are some changes that you all need to know and we all need to know to manage asthma better. We'll talk about the types of inflammation and asthma endotypes and phenotypes, which kind of drives the mechanism by which we make these recommendations in the guidelines. And I want to show you some evidence about how to identify patients with asthma who are at higher risk of having exacerbations, who we really want to get good control of and may need referral to other services. So these are the sort of headline recommendations in the guidelines in regards to treatment. They've recommended, I guess this middle point, they've recommended against using as needed SABA, so short-acting beta agonist Ventolin, to treat asthma, and that every patient who has a diagnosis of asthma should be treated with inhaled corticosteroids, or adolescents and adults. I guess children is a little bit of a different story. This is because it's a disease of airway inflammation, and if you don't treat the inflammation, you're not going to get control of their disease. The recommended started treatment is with inhaled low-dose combination inhaler with budesonide and formoterol. This is an inhaled corticosteroid and long-acting but short onset of action beta agonist. So formoterol, this is basically Symbicort or Rylast or similar drugs. The formoterol works within 5 minutes. Patients might say it works less quickly or less effectively than salbutamol, but I'll show you some evidence of saying that it's effective. And we want you to use it, to start with in patients with minimal symptoms as their reliever instead of using SABA. so that when they have symptoms, they get some inhaled corticosteroid. So you're not treating just the bronchoconstriction, but you're treating the thing that causes the bronchoconstriction and preventing them from deteriorating. There's also a guideline suggesting to give asthma medications via inhalers, not nebulizers. I think that this is so that, I mean, if you've got a patient on a nebulizer, they're not going to learn how to use an inhaler properly. They get confused about which medication to use. They're not typically using inhaled steroids by a nebulizer, they're getting salbutamol. And so they're just going to use increasing doses of this medication and then end up with a moderate to severe exacerbation. I'm trying to go to the next, here we go. So I'll show some data from this study in 2019. So this is to try to test the theory of this anti-inflammatory reliever therapy, or AIR. So the study is in patients with mild asthma who are managed in the community with just PRN SABA. They were randomized to either getting albuterol only on a PRN basis, inhaled corticosteroid budesonide maintenance daily, or it's twice a day, and budesonide formoterol, the ICS LABA combination inhaler, to use on a PRN basis. And it was one puff of 200 each time they had symptoms. In these studies, they measure a number called the annualized exacerbation rate. So they take how many exacerbations they're going to have and then work out how many they would have in a year per patient. So patients on the salbutamol would have 0.4 exacerbations a year versus the LABA ICS and even just the ICS group who had lower exacerbations per year, so 0.2. Right? So their risk of having exacerbation was 51% lower if they had ICS than if they were just on SABA alone. And the number of severe exacerbations was also significantly less in patients who had inhaled corticosteroid and long-acting beta agonist versus those that just had short-acting beta agonist. And there's on the right here are some Kaplan-Meier graphs showing a clear variation in the curves on patients who had salbutamol only, having a higher chance of having exacerbation than those getting inhaled steroids. Interestingly, there's no difference in the exacerbation rate, or not a significant difference in those who had maintenance steroids or just this PRN protocol. It is noted that the patients on the maintenance steroids did have less symptoms than those who had the PRN only. So if you've got a patient who has a chronic cough, for example, you might want to opt to have them on inhaled steroids all the time rather than on a PRN basis. But they can usually titrate it themselves as well. They measured how much steroid these patients ended up needing over the year of the study. And actually, the ones that were getting inhaled steroids got less oral steroids over the course of the year than people who only had a short-acting beta agonist, because they ended up with less moderate to severe exacerbations. So 17 milligrams of pred in the salbutamol only group, or albuterol, versus 7.5 in the budesonide ICS LABA cohort. There was also less use of inhaled corticosteroids in the PRN group, the budesonide formoterol group, than the people that had it as a maintenance dose, with no significant change in their number of exacerbations. This is another study in a population of asthma patients from Sweden, so I think this is probably reflective of Australia too. They've defined overuse of salbutamol as needing to buy more than 2 canisters a year. This is based on the definition of well-controlled asthma is needing to use your reliever less than 2 days a week. So if you take that out to a year, that's 2 canisters a year that they bought. So patients that buy more are overusing the Ventolin because they're not controlled. 30% of asthmatic patients in Sweden overuse Ventolin, and I reckon that's probably similar to what we have here. With increasing numbers of, or increasing doses of salbutamol, increasing prescriptions for salbutamol, there's an increased rate of exacerbations or less exacerbation-free survival in these graphs. And it's a linear sort of correlation. The more salbutamol they get, the more chance they're having an exacerbation. This is, I think, reflects that they're using tons of this sort of palliative medication to treat the symptoms without treating the underlying cause or the underlying inflammation. and that triggers an exacerbation, ends up needing steroids or seeing healthcare attention, ends up in hospital with the increased risk of cardiovascular events that would be associated with a severe exacerbation of asthma. So the summary of the treatment for asthma in these new guidelines is that everyone gets low-dose inhaled corticosteroid with a long-acting beta agonist, and they've recommended formoterol because it's short onset of action and because the studies where we've tried this type of treatment is with that drug. There's two tracks. The preferred track is this ICS formoterol combination, where you start with just using it as the PRN, like you would just say, you've got symptoms, use Ventolin, you've got symptoms, use this puffer with steroid in it. Then if they have persistent symptoms, you add maintenance and a reliever at low dose, and then you have persistent symptoms, you add a medium dose, and then you go to high dose or adjunctive medications. Meanwhile, you're managing their adherence and comorbidities and everything else. The less preferable option is to use preventer or a controller with just maintenance inhaled corticosteroid, and then a second puffer in the salbutamol. And they recommend that when they take Ventolin or salbutamol or Sava, they need to use an ICS at the same time, which patients aren't really going to do. So the first track gives them one puffer. It's a clear progression. It should make it simpler for the patients, optimize adherence, and we can see that it prevents exacerbations. That's it for the treatment, but now into why we use the inhaled steroids in the first place. So as we've got more knowledge of asthma and we're doing more sort of molecular tests and finding more molecules, we found two distinct pathways that occur in asthma. There's Th2 high and Th2 low. Th2 is the T helper type 2 cell drives this type of inflammation on the left-hand side, which eventually leads to high eosinophils in the airway and subsequent inflammation and hyperresponsiveness. Th2 low asthma is driven by different mediators, and you don't see eosinophils in the airway, you see neutrophils, and you might see no cells. The other thing that you see in type 2 high asthma is in the airway, these mediators stimulate nitric oxide to be produced, and we can measure that in the breath, and that is something that's made the guidelines as both a diagnostic and monitoring tool, which I'll talk about a bit later. So the type 2 high asthma is the classical asthma that we've been taught and we're all aware of. So this is most of asthma, 50% of mild to moderate asthma. It's higher in severe asthma. It's associated with worsening lung function, more frequent exacerbations, and more severe exacerbations. You can divide this group into allergic patients, so the dust, grass, pollen, allergies triggers the asthma, and non-allergic. So they still have the inflammation, but they don't have the allergic trigger. This is often related to allergic rhinitis, atopic dermatitis. It's that sort of phenotype of patient. Even though they are worse with more exacerbations, they actually respond quite well to steroids. So these are the ones where the inhaled steroids really work well, and the oral steroids work quite well as well. We can easily identify these people with a blood test and measuring the amount of nitric oxide they breathe out and the sputum eosinophils. So the serum eosinophil count in this group, we call it elevated if it's more than 150 cells per microliter, which is 0.15. When you get bloods for a full blood count, that's never marked as abnormal. Abnormal is 0.5. That's probably because when they did these reference calculations, there is a proportion of patients with allergies that aren't identified, and so that number's higher. But the reality, you should have less than pretty low eosinophils. Yep. The type 2 low asthmatic patients are the ones that don't have eosinophils, don't have allergy. This is a different group. It's harder to pick these patients. These are the adult onset patients with comorbid obesity and other conditions. They have varied presentation. There's not classical. They don't respond as well to inhaled corticosteroids. It's still the recommended treatment because we don't want to miss the people with more severe, with the type 2 high inflammation, but these guys don't respond as well to inhaled steroids. We're developing treatments for this group, but they're harder to treat. What we do is take a treatable traits approach. You might have heard that. That's been talked about a lot in respiratory, where we try to identify comorbidities and other things that trigger the asthma and treat that to optimize the airways disease. I mean, this table is the most prevalent comorbidities in asthma. A to B on the far right won't apply here, but respiratory infections, so making sure they're vaccinated, optimizing their dental hygiene so they don't get aspiration infections, to prevent exacerbations, treating their reflux, treating their sinusitis, which may or may not be allergic in etiology, and treating their obesity would be the ways to approach these patients. So how do we identify people who might be in the higher risk phenotype, the type 2 high phenotype? And how do you predict people that you see that, are going to exacerbate or at a high risk of exacerbating, who need to be watched closely and need to be started on treatment, sooner, and need to be investigated harder? So on the bedside, you got the patients with more comorbidities are more likely to exacerbate, mainly reflux. Patients with worsening symptoms or the symptom scores that we use have a higher rate of exacerbation. If they've had exacerbations before, they're more likely to exacerbate again. And if they're using lots of salbutamol, as I've described. But there are some more objective markers that we can use, the peripheral eosinophil count and this FeNO, the fraction of exhaled nitric oxide, which is a measurement of this Th2 high inflammation at the breath that we can do in the lung function lab quite easily. This is a study. So this data is from a study where it's one of the studies for Dupixent, which is a biologic medication used for asthma, allergic rhinitis, atopic allergic dermatitis as well. So the cohort is patients with moderate to severe asthma who have had one severe exacerbation in the past year. They analysed the placebo group, so the ones that didn't get dupilumab, and tried to see what serum or other markers predicted their risk of having exacerbation. And patients who had an elevated fraction of exhaled nitric oxide, so greater than 50, had a 54% increased rate of having a severe exacerbation than people who had a low fraction of exhaled nitric oxide. So it's predictive of having an exacerbation. Patients who have elevated eosinophils had an increased risk of having an exacerbation as well. And combined, so if they had high fraction of exhaled nitric oxide and a high eosinophil count, they had an odds ratio of 1.77 of having an exacerbation in a group of patients that already have exacerbations of asthma. The highest group of patients, the highest risk group of patients are those that had high FeNO, high eosinophils, and had more than 2 exacerbations in the previous year. Another thing to note, when you give them prednisone, the eosinophils go down to 0 within 24 hours, so you've got to measure it beforehand. The guidelines don't, they leave phenotyping the airways to people who need medium to high dose steroids, and that's what we do in the respiratory clinics, but it's pretty easy to do, and I think it's helpful. And if patients come, repeatedly with lots of symptoms and are using lots of salbutamol, then I think we should get the ball rolling and try to identify what's the cause of their disease. These biomarkers in a general population also predict progressive lung function decline. And it is worth noting that some patients with asthma have these markers without classic symptoms or with minimum symptoms, but they can still have progressive lung function decline over time. This is a Danish population cohort. I think it's about 2,000 people. They did spirometry, fraction of exhaled nitric oxide, eosinophils 10 years ago and then recently, and tracked it over time. And just essentially these graphs show that with increasing eosinophilia, increasing fraction of exhaled nitric oxide, there was worsening or accelerated lung function decline over time. This was worse in patients with asthma and in patients with asthma and persistent airflow obstruction. So they've got this inflammation that's going on constantly. The airways are getting fixed and they get COPD essentially over time. The guidelines do make a lot of recommendations about spirometry and lung function testing. This is a big issue, I think, in Australia. It's hard to access spirometry. It's not rebounded very well. COVID's put it, a stop to it in a lot of GP practices. So it's hard for patients to access, but it's really important to diagnose and monitor the condition. We know that there's a high rate of under and overdiagnosis in asthma, which means patients are getting steroids unnecessarily or not getting steroids when they need it. And you're having other missed pathology. So really, these recommendations, just to run through them, when you see a patient that you think have asthma, they need to have spirometry. One, to see how bad it is, and two, to confirm the diagnosis. Bronchodilator response confirms the diagnosis. Shouldn't happen in normal patients. Just because the bronchodilator response is normal doesn't mean they don't have asthma. It means on that day their asthma wasn't bad. So sometimes we repeat it, and you can see if the FEV1 varies over time significantly, then that is also considered diagnostic of asthma. Why I've mentioned pheno so much is that, well, it's useful, and it's also made the guidelines here. We can do this test in the lab. It takes about 5 minutes. They just breathe out into a tube. Kids can do it. And it has made it's, some guidelines say an elevated pheno more than 50 with the right symptoms is a diagnosis, gives you a diagnosis of asthma, even when you don't have the other features. So it's useful. And then, if we really don't know, we can do a bronchoprovocation test in a respiratory lab to confirm the diagnosis. They've also suggested that if you see a patient who someone else has said they've got asthma, we know that heaps of them get the wrong diagnosis, so we should check. I use it, well, respiratory physicians use it a lot. So anytime I make a change to treatment, after they've had an exacerbation, and really because there's this group of patients that can have worsening lung function over time, you should check on it semi-regularly. These guidelines recommend every 2 years, even if they feel well, because they don't always perceive symptoms well. And then I'll just go through some of the biologics, mainly because it kind of ties neatly into this, and you'll see them in your clinics, so that you're aware of them. So this is the type 2 inflammatory pathway, with the airway at the top, allergens, whatever goes in, and then it triggers this pathway ending in the eosinophil, and ending into airway inflammation, bronchoconstriction. Along this pathway, there's a bunch of interleukins. These things in red are all the different drugs, mepolizumab, benralizumab, dupilumab, that block different receptors and then stop the inflammation, so they don't need to use steroids. To get onto these drugs, the general criteria for the PBS is they've had exacerbations and symptoms despite being on high-dose corticosteroids for a prolonged period of time. They have the markers of the inflammation, so the eosinophils and the pheno. We've got an objective diagnosis of asthma, and they've seen the same respiratory physician for 6 months. They're pretty safe medications. We check for strongyloides because you're at increased risk of parasitic infection on these drugs, but you're not at an increased risk of other infections. The main thing is anaphylaxis, and so the first couple of doses, 3 doses, are recommended to be given in a supervised environment. We usually ask the GP to supervise this with the nurses in their practice, because often specialist rooms don't have that facility. Indications for specialist review for asthma. I mean, it's 1 in 10 Australians, huge burden of disease. We can't see them all, but we need to identify patients that are unwell, because there are really good treatments that can get people back to near remission of the disease. So if the diagnosis is uncertain, that would be an indication. If they've got ongoing symptoms despite medium dose steroids, so you've gone from air to MART to medium dose and still have symptoms, that's when you should probably send to someone for a look over. If they've had a severe exacerbation, if they've got COPD as well, if they've got occupational asthma, because these patients can have faster lung function decline. I see patients sometimes that have had lots and lots of oral steroids, and really, if they're getting more than 2 courses of prednisone for something, probably means it's a severe something that needs to be looked at a bit more closely. And I think currently the climate, it'd be good to be able to have access to your local lung function lab. I don't think everyone needs to see a respiratory physician. They just need to test to see if they're stable or not, if it's progressing or not, and to help with the diagnosis. And we know it's not rebounded well, and it's actually hard to get people to train to do it. So that's kind of, I'd advocate for meeting with your local respiratory physician and try to get some testing done. So in summary, it's a chronic condition. I hope I've explained why we need to use steroids to treat it. We should be testing more to try to get objective data on our patients to help with diagnosis, and there are good treatments available now. So if you see patients with severe disease, please send them for assessment, because we can do things to get good control of their asthma. Thanks.
Fabulous. Thank you so much, Lewis. So I'm going to invite both speakers back to join me. Yep. Sorry, I've sort of got my screen in a funny position. We've got some questions to ask. If it's okay, Lewis, I might head straight to you as you sort of hot off the press with the asthma. But don't you worry, Matthew, I've got some questions waiting here for you. So two, I think, really relevant questions. One was around why the higher dose Symbicort, the 412, is not to be used for SMART. And then sort of in line with that, about is it appropriate to withhold inhaled steroids while you're waiting to do spirometry, given your comments about sort of some of that. So
Yeah.
off you go.
Yeah, so I guess the first part of that, the one is the trials are all done in lower doses of inhaled corticosteroid. The 400 dose, I don't know who, like, I don't really use that dose. A high dose of budesonide is more than 800 micrograms. So usually I do the 200 dose, 2 in the morning, 2 at nighttime, and then that can be a pair-end dose as well. I think the answer is the trials were done using this strategy with lower doses, and we're trying to minimize the amount of steroids I have, and the data has shown that the lower doses are sufficient to make an improvement. Is all I can say.
That's exactly where I'd go to. The trials were really very clear that you didn't need to use the higher doses, and you started to get the risks versus the benefits of being on long-term inhaled steroids. So what about the withholding?
Yeah, so yes, if you've got someone on inhaled corticosteroids, then as I say, the airways aren't going to, if you've controlled the airway inflammation, then they're not going to, they shouldn't bronchoconstrict as much. That's the goal. But then, yeah, if they've been on inhaled steroids for a while, the spirometry may be negative. And the pheno should be low as well, because we're treating that. It depends on how bad they are. Like if it's mild asthma, then yeah, you can just withhold it, have them just use it as a PRN. Usually for a spirometry, we want to withhold drugs for 48 hours. That's more for the long-acting beta agonist. Inhaled steroids, yeah, I mean, if you can afford to withhold them for testing, then yes, that's useful. But if they're sick enough that they need the medication and it's really asthma, then you wouldn't want to pull it away to make them exacerbate. You know,
being clinically relevant at that point.
Yeah, and sometimes I use, I mean, repeated spirometry can help, because some days they're worse than others, and you can just see the difference over time. And they usually, if they're so bad that you can't withhold it, then they probably have obstruction, and it's probably more marked, and you can get information that way.
Thank you. There is another asthma question, but I'm going to come back to you because I'm going to move to Matthew, who's been waiting very patiently there. So there are some questions with respect to what is the role of X-ray in the follow-up of patients versus a CT scan?
Multimodality imaging is great. I don't tend to do repeat CT scans very often. It'd be somewhere in the 3 to 6 month post the pleural infection. Chest X-rays, I tend to use pleural ultrasound in my clinic. I have access to one, but chest X-rays are very kind of low dose, and I would use them particularly in the primary care setting where you don't have access to pleural ultrasound. You just want to see radiological surveillance. I guess what I was trying to get at is don't X-ray too often, because there is a radiological lag. So if the patient's improving clinically and the CRP is dropping, you've probably got improvement, and you don't need to prove it with an X-ray every time you see them.
You sort of raised pleural ultrasound. So is that something that is more worthwhile? I mean, do the local ultrasound clinics do that as well?
I think it's always operator dependent, and you had to see the patient when they've come out of hospital, because they'll always look abnormal, right? So if you don't have the older images to compare to, it's difficult to make the call whether there's been improvement. A chest X-ray is much easier to access and then compare, because it's much more accessible in the community. So it's very helpful for me, because obviously I transitioned from inpatient outpatient, but it might be difficult to interpret. if you send them for a pleural ultrasound in its isolated setting.
Perfect. Thank you. A, a really interesting question. What about considering the diagnosis of TB in these
Yeah,
patients? Yeah.
absolutely. We always do, particularly in the area in which I work. There's two distinct entities, TB pleuritis and TB empyema. We always consider with any pleural infection that this could be TB. TB pleuritis normally is just a hypersensitivity reaction. And in this case, it was a very exudative polymorphonuclear infection, while TB pleuritis tends to be a lymphocytosis. It tends to be an exudative effusion. But those are the two differences. TB empyema is another, entity. And normally TB is not found in the pleural fluid. So you have to sample the pleural surfaces to get the bacteria. Running AFBs or DNA kind of amplification test on the pleural fluid is not very helpful. So another kind of adjunct test that we always run on all our pleural samples is something called ADA, and ADA can help increase your, thought about TB. But everything is fairly consistent with a bacterial empyema. So high-grade temperatures, really high CRP, loculated effusion, and really no parenchymal infiltrate that would suggest TB, although it's always high up in our differential.
Thank you. There was just a quick question, really, because I think you did answer it, but it's why the intrapleural ultraplay was used in this particular patient.
Yeah, every day we make an assessment. We obviously want to see biochemical response, which it was lagging in the first day, and then source control. So is there still pleural fluid there? And that can be done X-rays, ultrasounds on a daily basis on ward rounds. And based on that, high biochemical response, high CRP, ongoing temperatures, ongoing pleural collection, and we're not draining very much. Putting a bigger drain doesn't help, and the literature supports that. Actually putting in these enzymes to break down the pleural fluid and the kind of thick pus that's in there will definitely help.
Yeah, I must say it's come a long way from when I was working in hospitals. It's fantastic. Thank you, Matthew. So back to you, Lewis. So what about children? Because we haven't really talked about the sort of, are there changes to the way in which we manage our 12 and unders?
Yeah, look, I don't know. I don't know too much about children. There's obviously the concern for growth suppression with inhaled steroids. I had a quick look at the GINA guidelines because I thought someone might ask that. You can still use inhaled steroids. It's kind of the same, but you start off at really low doses, and you want to be sure of the diagnosis, right? Before
It's
you
just that
give them this
long-acting
treatment.
bronchodilator that's the tricky bit, isn't it?
Yeah.
Yeah. Yep. So we still look at the guidelines for the children is what we're needing to do.
I'd check. Yeah. And there's still like the comment in the guidelines is it's there's not enough evidence to make a broad sort of recommendation about the air protocol that I described.
Yep. Can I just call out too at this point in time? So what we're really having to do is change the culture of our patients, self-managing with their SARBs, going into the pharmacy, just getting SARBs and never coming to see us and letting us know how badly treated they are. And the importance of us actually interrogating everybody with asthma about how often they're using a SARB and changing their way of thinking, because it can be quite hard because they're addicted to the whack that they get from their SARB without realizing they're just not doing their asthma any good at all.
Yeah, and they can still have severe exacerbations even though it's mild.
I think we're going to be pushed out. We've got Jasmine here, but I'll just very quickly, the role of Trelegy Ellipta in asthma.
So I mean, for one, it's a dry powder inhaler, so there's less drug deposition to the small airway. There's 2 doses, so if you're going to use it, you've got to make sure it's the higher dose. Some people like Trelegy. I don't usually use it for asthma personally. But if they're on it, I don't change it if they're on the right dose.
Yep, and if they know how to use the device properly.
Yeah.